Hello class, this is Professor Edwards-Diaz with your lecture on care of the patient with a brain tumor. In this lecture, we will discuss the etiology, pathology, and classification of brain tumors. We'll describe the clinical manifestations and nursing assessment related to brain tumors and its diagnosis and monitoring. We're going to identify complications and treatment options and related collaborative nursing assessments and interventions. We'll utilize critical thinking in the nursing process to care for the patient with a brain tumor. We'll also discuss evaluation of the patient's response to medical, surgical, and nursing interventions, and discuss any psychological, psychosocial, socioeconomic, cultural, spiritual, and ethical factors related to caring for a patient with a brain tumor. A brain tumor is an abnormal mass of tissue in which cells grow and multiply uncontrollably, seemingly unchecked by mechanisms that control normal cells. Over 1.3 million Americans are living with a primary or secondary metastatic brain tumor today. Nearly 1/3 of brain and central nervous system tumors are malignant. So this means that the brain and the spinal cord can be affected. Each year, approximately 17,200 people die from a malignant brain tumor. The risk of developing a brain tumor is very low, with a lifetime risk of under 1%. There are numerous types of brain tumors, and they are classified as either benign, non-cancerous, or malignant, cancerous. Classifications also based on the location of the tumor and their histologic characteristics, meaning what they look like under a microscope. And tumors are also classified by the World Health Organization classification system. They can be classified from least aggressive, which is grade 1, to most aggressive, or grade 4, depending on the rate of growth and the behavior of the cells. Primary brain tumors are tumors that originate in the brain and originate from brain cells, brain meninges, nerves, and glands. Primary tumors are diverse and can range from slow-growing to aggressive and can either be benign or malignant. So these tumors are also classified by the type of brain cell involved and the location where the cancer evolves. Primary tumors progress locally and rarely metastasize outside of the central nervous system. And approximately 72% of primary brain tumors are benign, while 28% are malignant. Benign tumors are generally slow-growing and are unlikely to spread. However, with continued growth, they occupy space in the brain, causing changes in the intracranial pressure or press against other structures of the brain. Malignant tumors, on the other hand, are generally fast-growing and considered cancerous and can spread to other parts of the brain or spinal cord, and their rapid growth damages central nervous system structures. And because these are primary brain tumors, whether they are benign or malignant, they generally do not metastasize to other body systems. Secondary brain tumors are cancers that are metastatic from other areas, primarily the lung, breast, kidney, bowel, and skin. So there are over 120 types of brain tumors, but this lecture is going to cover the most common ones that you may encounter in your future practice. Starting with the primary tumors that you're more likely to hear about or see in practice, starting with gliomas. And gliomas are the most prevalent type of adult brain tumor, accounting for 78% of malignant tumors. They arise from the supporting cells of the brain called glia, and they often originate in the cerebrum. Astrocytomas are the most common glioma, and glioblastoma multiforme, or GBM, is the most invasive type of astrocytoma. These tumors grow rapidly, they spread to other tissues, and have a poor prognosis. Oligodendrogliomas are derived from the cells that make up myelin, or make myelin, which are the fatty coverings that protect nerves. And these are slow-growing tumors that do not metastasize outside of the CNS. Although they are slow-growing, they are classified as malignant because of their damaging properties. Continuing with the primary brain tumors, meningiomas are the most common benign brain tumors, accounting for roughly 37% of all primary tumors. And these tumors are slow-growing and originate from the meninges, or the layers of the brain, and typically involve arachnoid cells. Although mostly benign, these tumors can still cause damage because they occupy space in the skull. And remember, anytime there's space taken in the skull, it's going to increase the intracranial pressure. Next on the list of primary brain tumors is the pituitary adenoma. An adenoma is a type of tumor that grows in the gland tissues. Pituitary adenomas are benign, develop from the pituitary gland, and tend to grow at a slow rate. However, depending on which direction they grow and which part of the brain that they press against, they can cause vision and/or endocrine problems. The acoustic neuroma or vestibular schwannoma are benign, slow-growing tumors of the 8th cranial nerve that connects the ear to the brain. And although these tumors are benign, they can cause serious complications and even death if they continue to grow and exert pressure on the nerves and eventually the brain or the brain stem. So we're going to move on to the secondary brain tumors or cancers. Metastatic brain tumors include tumors that arise elsewhere in the body and migrate to the brain, and this is usually by way of the bloodstream. Metastatic tumors are considered cancerous and are malignant. Metastatic tumors to the brain and spinal cord affect 1 in 4 patients with cancer, or about 200,000 people a year. And up to 40% of people living with lung cancers will develop metastatic brain tumors. Other malignancies such as breast, liver, kidney, colon, and skin, specifically melanoma, cancers have a tendency to metastasize to the central nervous system. Clinical manifestations of brain tumors are dependent on their location in the brain. Different parts of the brain affect different functions in the body, such as movement, vision, and speech. Remember that there is limited space within the skull. Signs and symptoms of brain tumors typically develop when abnormal tissue expands and pushes against healthy brain tissue, so the tissue around the tumor swells, disrupting the equilibrium between the brain, blood, and CSF. This is why primary brain tumors that tend to be benign are often referred to as space-occupying lesions that may cause an increase in intracranial pressure as they grow. Other signs and symptoms of a brain tumor include headaches, which are often the first symptom of a brain tumor, and these headaches can be mild, severe, persistent, or come and go, but not all headaches indicate that it's a tumor, so it's important to ask about the history. If the person never has headaches, this could be concerning. Also, if they have a headache history, ask if this headache is different from previous headaches, and ask how is it different. Other symptoms include unexplained nausea and vomiting, usually projectile vomiting, visual disturbances like blurred vision, double vision, loss of vision in one eye, loss of visual field on the same side but in both eyes, changes in speech and word-finding difficulties, memory problems, personality changes, irritability, extreme drowsiness, motor weakness on one side, loss of balance, dizziness, and seizures, especially if the person does not have a history of seizures. The history of illness, the manner and the time frame in which the symptoms evolved are important parts in the diagnosis of a brain tumor. So when gathering a history, you want to ask about symptoms, when they started, how long do they last, are they continuous or intermittent, is there anything that makes the symptoms worse? Anything that makes them better? Any new or worsening symptoms? Any recent changes in medications? Any history of brain injury or surgery? Any recent accidents or injuries involving the head? Then you want to conduct a neuro exam to indicate which cranial nerves could be involved. A CT scan of the head would typically follow and could provide information of the number of tumors, their size, density, and to evaluate other brain structures involved. MRI would produce better images and would catch smaller tumors or lesions on brain stem or pituitary region. MRS scans look for changes in the chemical makeup of the brain and is typically done at the same time as an MRI. PET scans would be typically done to gather information that could influence treatment decisions, and these scans involve injecting a small amount of radioactive solution to reveal cancer cells as they absorb the solution faster than normal cells. SPECT scans take three-dimensional images of blood flow in the brain, revealing higher blood flow, such as seen in tumors, and they'll be brighter on the scan. Lumbar puncture can be done to collect CSF to test for malignant cells, as CNS tumors can shed cells into the CSF, resulting in metastasis. Specific treatment depends on the type, location, and accessibility of the tumor. Radiation therapy is a cornerstone treatment for many brain tumors. It uses X-rays and other forms of light energy to destroy cancer cells and malignant tumors, or to slow the growth of benign brain tumors. An example would be to use external beam radiation therapy, which is the most common type of radiation therapy for brain tumors. It can be directed to the tumor and nearby brain tissue. Another example is stereotactic radiosurgery, which uses smaller, more targeted beams of X-rays to spare healthy surrounding tissue. MRI-guided laser ablation and laser interstitial thermal therapy uses intraoperative imaging to locate tumors and precisely destroy cancerous cells with lasers or heat. Chemotherapy is rarely used as a standalone treatment for brain tumors. It's typically used in conjunction with radiation therapy and/or surgery. And the greatest challenge in chemotherapy of brain tumors is that the medication needs to cross the blood-brain barrier so the tumor can be treated. Pharmacologic therapy includes the use of corticosteroids, which are useful in relieving headache and alterations in level of consciousness. Dexamethasone, or Decadron, is administered to reduce inflammation and edema around the tumor. With increasing intracranial pressure, medications like mannitol or hypertonic saline can also be started. And anti-epileptic medications will be used to prevent seizures and to prevent spikes in intracranial pressure. The goal of surgery is removal of the tumor without increasing neurologic symptoms or to relieve symptoms by decompression. A craniotomy is the most common surgical procedure for all types of brain tumors, and this will decrease ICP and decompress the brain, but this also provides surgeons access to the brain for tumor resection. In awake brain tumor surgery, patients are kept sedated and comfortable, but they're awake during surgery, so surgeons can ensure normal brain function is unaffected. In neuroendoscopy, surgeons enter the brain through other areas of the body, like the nose, to reach certain regions of the brain. Cameras are inserted through these areas to assist surgeons to visualize these areas of the brain. So some post-surgical complications to be mindful of. Increased ICP can severely decrease cerebral blood flow, decreasing cerebral perfusion that can lead to secondary injury or brain herniation. Bleeding is a risk post-op, and this depends on the tumor, location in the brain, and the proximity of the tumor to blood vessels. Bleeding can cause an increase in ICP, so these patients need to be watched closely with frequent neurologic assessments. Cerebral edema is another complication of tumor resection. Again, this depends on the tumor and its location in the brain. Edema can be located in and around the area where the tumor was resected, or along the path the surgeons took to access the tumor. An increase in cerebral edema also impacts the intracranial pressure. Serial neurologic assessments are used to monitor the patient's response to surgery. A corticosteroid, dexamethasone or Decadron, is often administered to prevent this complication. Seizures are also a possible complication that may occur post-op. Benzodiazepines are often used in acute seizure, and antiepileptics are used for seizure prevention. Venous thromboembolism, or VTE, is another risk to consider post-op. Surgical procedures, the presence of cancer, and immobility place patients at risk. Infection is or should be rare with surgical procedures, since these procedures are conducted under sterile conditions. However, infection can still happen. Nursing assessment involves neurologic assessments, including level of consciousness, orientation, and motor strength. Remember that changes in level of consciousness are the most sensitive indicator of increasing ICP and can clue us in on complications like intracranial bleeding and swelling. Monitor vital signs. Watch for Cushing's triad: decreased heart rate, increased systolic blood pressure with widening pulse pressure, and irregular respirations. This is a late sign of increased ICP and can signal brain herniation. Monitor electrolytes. Serum sodium should be kept within normal limits. Higher end of normal is preferred to prevent fluid movement into cells. You want to monitor input and output. Patients are at risk for diabetes insipidus, large amounts of dilute urine, and syndrome of inappropriate antidiuretic hormone, or SIADH, small amounts of concentrated urine. Assess the patient's pain and treat appropriately with opioid medications. Monitor for infection at the surgical site. Check the patient for fever, chills. Check the site for redness, swelling, pain, bleeding, or any discharge. Some nursing actions for you to consider. Elevate the head of the bed 30 to 45 degrees and maintain the head in a neutral position. This promotes venous outflow of blood from the head and helps to keep the ICP down. Avoid turning the patient onto the operative side. Think about this. If a tumor is resected on one side of the head, there's going to be a space there. So turning the patient onto that side risks movement of the brain. Avoid this. You also want to administer corticosteroids like dexamethasone or Decadron, and this given post-op helps to treat and prevent cerebral edema. Administer anti-epileptic medications because this helps to prevent seizures which can occur as a result of tissue disruption. And you want to prevent thromboemboli with the use of sequential compression devices and heparin as ordered. And finally, some other considerations. We also want to see how the family is managing. The family needs to be reassured that their loved one is receiving optimal care and that attention will be paid to the patient's and family's concerns. You want to get the family involved because educating family members on how to care for their loved one with additional physical, cognitive, and sometimes behavioral impairments is necessary. Collaborate with additional support systems like social work, support groups, counseling services, and help the family investigate what supportive or financial resources are available to help decrease the burden on caregivers. And this concludes the lecture on care of the patients with a brain tumor. Thank you for your time and happy studying.